Welcome to Osteobites, everyone. My name is Anne Graham. I'm an osteo warrior and executive director of MIB Agents. Today, we have my favorite kind of Osteobites with two really great people and a bunch of really awesome panelists as well. The topic today is amputation for osteosarcoma, patient and surgeon perspective. Dr. Kurt Weiss is our guest. And the patient perspective is courtesy of MIB Junior Advisory Board President, Kara Skrubis. A little more on Dr. Weiss. Dr. Weiss is an osteo survivor, an amputee, osteosarcoma researcher, and associate professor of orthopedic surgery with joint appointments in surgery and pathology at the University of Pittsburgh Medical Center. He is also our 2021 Outsmarting Osteosarcoma winner. Dr. Weiss is a founding member of the Musculoskeletal Oncology Research Initiative, Pittsburgh Cure Sarcoma, the Pittsburgh Sarcoma Research Collaborative, and the Pittsburgh Center for Bone and Mineral Research. Amazing you have time to share with us today. He is also a peer reviewer for multiple medical journals. He has served on multiple National Cancer Institute study sections. He's a member of the Musculoskeletal Tumor Society, for which he serves as chair of the research committee, and the Connective Tissue Oncology Society, for which he has served on the board of directors. Kara Skrubis was diagnosed with osteosarcoma in January of 2020. She received 9 months of chemotherapy and a left above the knee amputation, followed by 8 months of immunotherapy. Currently, Kara is 20 years old, living in Buffalo, New York, attending the University at Buffalo, pursuing a child life certification, which she'll be awesome at. In the meantime, Kara serves as the MIB Junior Advisory Board President. This episode is sponsored by BTG Specialty Pharmaceuticals. BTG provides rescue medicines typically used in emergency rooms and intensive care units to treat patients for whom there are limited treatment options. They are dedicated to delivering quality medicines that make a real difference to patients and their families through the development, manufacture, commercialization of pharmaceutical products. Their current portfolio of antidotes counteracts certain snake venoms and the toxicity associated with some heart and cancer medications. Their drug, Varaxase, is for high-dose methotrexate toxicity. And that's it. Dr. Kurt, over to you for your quick intro, please.
All right. Thank you, Anne. And always a pleasure and honor to do anything associated with MIB. Hardest working osteosarcoma survivor advocates in the business. And thank you for having me. So I do have a very short presentation. Being a surgeon scientist, I'm unable to communicate except with a PowerPoint. So I'm going to just show a few slides, and maybe that'll start as the catalyst for some conversation.
My name is Kara Skrubis, osteo warrior and MIB president of the Junior Advisory Board 2022.
I'm Mia, also an osteo warrior. And I am the MIB Junior Advisory Board Vice President, and I am honored to be here today.
I am Kerrigan Nelson, and I am 21 years old. I'm on my third fight with osteo, and I've received above the knee amputation on my left leg, and I proudly sit on the junior board of MIB Agents. I am really excited to be here.
And I'm Christina Iptoma, mom to Osteo Angel Dylan, and I'm the Director of Scientific Programs for MIB Agents. And we'll hand it off to Dr. Weiss to go ahead and get started.
Like I said, I'm going to bang through this pretty fast. This is borrowed from a talk I gave to the medical students a couple of years ago that talks about some of the pertinent issues that we're going to talk about today. Okay, so let's move along. If you want to stop me, go ahead and stop me. It's fine. Everybody on this call has got a story, and here is some of mine. If you take a kid and give them a horrible metastatic osteosarcoma of the proximal tibia, and you introduce them to these mentors in surgery, Henry Mankin, Mark Goodman, Rich McGow, you might get yourself a orthopedic oncologist. If you take the same kid, give them a horrible metastatic osteosarcoma, and introduce them to these scientists, Chris Evans, Jeannie Kleinerman, Sean Khanna, and Steffi Osterreich, you might get yourself a translational oncologist. So let us continue with the villain of this story, osteosarcoma. Just as a very brief overview, you guys all know about this disease more than any textbook can say. And the biggest problem with osteosarcoma is not where it starts, but where it ends. And that's why all of my research is on how to figure out and stop osteosarcoma metastasis to the lung. That's what I go to sleep and wake up thinking about every day. The prognosis was abysmal before we were audacious enough to give children and teenagers chemotherapy. The good news is that we turned that number on its head very, very quickly in scientific terms, almost in the span of about 15 to 20 years. The bad news is we haven't budged in over a generation, and that is not acceptable. And we're still doing pretty crappy on patients like me who had metastases at the time of diagnosis. So the treatment of osteosarcoma, if you're not familiar, is a surgery sandwich with the two buns or pieces of bread being chemotherapy and the stuff in the middle being surgery. So again, to illustrate in pictorial format what we talked about before, we sort of really had it by the horns between 1970 and 1985. And after that, we haven't done much, and that's not okay. Because my prognosis in 1989, when I was diagnosed, is pretty much the same as my patient, Katie. She is a sophomore at West Virginia. She's doing great. But my prognosis was the same as Katie's was in 2015, and that is not okay. Briefly about margins. If the osteosarcoma is the fruit, the part of the orange that we eat, if myself or Dr. Healy or some of the other surgeons go in with their melon baller and just scoop out the tumor, that's not okay. That's not enough. We will leave osteosarcoma cells behind, and that is no bueno. So what do? Well, we insulate the tumor with our wide margin. We take a normal layer of patients in 360 degrees in 3 dimensions all the way around the tumor. So let's talk about bony anatomy. Again, this was borrowed from a talk I gave to the medical students. The very top end of the bone that's closest to your head is the proximal end, the distal end. So this is an arm bone, okay? This is a humerus. This bit, the proximal bit, is up by the shoulder, and this bit, the distal bit, is down by the elbow. And the stuff in the middle, we call the diaphysis, okay? And here is a distal femur of a patient of mine who I didn't think had osteosarcoma, but we did a biopsy, and that's what she had. And so here are her MRI pictures. This is sort of cross section of the femur. This is the right femur, which has the sarcoma in it. This is the left femur, which is normal. Same thing here, right femur, left femur. And so that's what I got to take out to get my good margin, to get my negative margin. Okay, I have to take the bone and surrounding tissue. Okay, so I don't draw these lines on the scans or on the patient, but I do draw them in my head when I'm planning out the surgery. This line here is from the biopsy. Can you guys see my mouse? Okay, awesome. This line here is from the biopsy. So I have to consider that when I did that biopsy, I contaminated this whole area with osteosarcoma cells. Everything must go, okay? So that is part of my negative margin. So keep your eye on that paddle of skin, because there it is. There is the femur with tissue all around it, and there's that paddle of skin. And I've taken into account that all of that area could be contaminated with osteosarcoma cells. Okay, so now I've taken out a third of this patient's distal femur, and I got to put them back together again. So we have these systems where we can build your femur with a bunch of parts that we can make modular on the fly. Think of it as advanced Legos. So here, and this is really what we do. So I will lay the resection specimen on a table, and I will build something that I think looks to be about the same shape and size. Then I will trial it in the patient. If I like the way it feels and I like the way it moves, then I will swap these components out with the definitive components and sew the patient up, and Bob's your uncle. And that's what the postoperative films look like for a distal femur replacement, removing all of the osteosarcoma. So that is the way limb spare is supposed to work. And that has held up pretty good for her. And she's even been on TV. So she's doing pretty good. Many osteosarcomas happen in bones that are not done growing yet, right? A lot of our patients are before the age of skeletal maturity. So these lines here are the growth plates. What do you do if you got to take out a sarcoma in a bone that's not done growing? Well, you got to figure out a way to grow the bone. And I'm doing one of these tomorrow, where I'm going to take out a chunk of the femur, and I'm going to replace it with a megaprosthesis like we just saw, and then we can expand it inside the patient. Now, the idea of an expandable megaprosthesis is not new, but you used to have to take the patient to the operating room and put an Allen wrench in their prosthesis and crank it out and make them a little bit longer. But we don't have to do that anymore. We can do it by remote control with these electromagnetic coils. So this is the way it works. And you can see in this spot, this is what it looked like when we put it in, and this is what it looks like after a few expansions. So pretty cool stuff. And all of that without a trip back to the operating room. Most of the time we're able to save limbs, arms and legs. Not always, wasn't always in my case and some of our panelists. When I do a transfemoral amputation or through the femur, this is the way I like to do it. Here is a cross section of the thigh at that level. So about mid-thigh. That is the femur, okay? That is the femoral artery and vein, okay? There's big psi, the sciatic nerve. So those are the structures that we've got to contend with when we're doing our amputations. And all this bit here, that is the muscles, the quadriceps in the front of the thigh, and these are the hamstrings in the back of the thigh. What I like to do is I like to go to the vessels early, because that's the hard part. I like to do the hard part first. And so I will go to the vessels, and then once they are under control, I will go to the bone, and I will cut the bone either with a Gili saw, or which is a flexible saw, or an oscillating saw. Now, you can handle big psi, the sciatic nerve, in a couple of ways. Way number one is the traditional way, which is that you stretch the sciatic nerve and you cut it and let it retract back into the soft tissues. I don't do that anymore. Nerves are kind of like teenage kids. They need something to do. So what I do now is I will take the cut end of the nerve and I will sew it into some of these surrounding hamstrings so that the nerve has something to grow into and something to do. And there's pretty good data to show that that decreases the incidence of phantom pain. So this, and then you close her up. You basically want a continuous sleeve of muscle all the way around the end of the femur, because in about 4 to 6 weeks, you're going to start beating on this. So it's got to be robust. It's got to be well padded with a lot of muscle. And so that's what I do. How do people do for real? This is me on the west rim of the Grand Canyon, and here is one of our wonderful Paralympic athletes. Well, people don't always do that great. Now, none of these data are specific for osteosarcoma survivors. So there's a research opportunity here. Most of the literature is for people who have had amputations done for bad vessels like vascular problems or from diabetes. So it's very much apples and oranges, but it's at least some extrapolation can be made. People get a lot of skin problems. I'm in that category. I have had a lot of skin problems. Our panelists are going to weigh in on that too. Most people heal their skin. Again, this is in people who have had vascular problems, but they found in this study of vascular patients that only 40% were able to use their prosthesis. So clearly there is work to be done. This is my tibia, my x-ray shortly after my allograft surgery. Now, I didn't start out with a mega prosthesis like we just saw. I started out with this allograft, which is replacing basically from here all the way to here of my tibia bone with a cadaver bone. Seemed like a good idea at the time. And so this is the going, gone slide, okay? So here's where I started. And then I had some repair work. And if you have a good eye, you can see that the condyles, the plateau of the tibia are starting to fall off. And now it's pretty well pulverized. I don't have much of a knee left. And the reason why is because this whole thing got infected. And when you've got an infection and when you've got a bunch of dead bone and a bunch of metal, things that don't have blood supply, you got problems. So I had that revised to this, which is a megaprosthesis that is potted into my allograft. Also seemed like a good idea at the time. And this worked pretty well for a while until it didn't. And that was revised to another one of these. And the infection came back for the millionth time. And at this point, I had had a major operation every 3 months for about 6 years on my leg, trying to eradicate this infection. And I was a senior at Notre Dame. And I said, you know what? I'm not doing this anymore. I'm spending all my time in the operating room. It's time for something different. And my surgeon, Dr. Goodman, and I mutually decided that after I fulfilled my duties as the president of University Bands, after the bowl game, I was going to have my leg amputated, and that's what we did. And yeah, so the infection came back, so this is my new normal. I had the transfemoral amputation. These screws up here are a more recent addition. About 10 years ago, I thought it would be a good idea to fall down a flight of steps backwards, and I broke my hip and pulverized my wrist, my right wrist, which is bad for a right-handed surgeon, but thankfully everything's okay there. But this is what my x-ray looks like now. So let us begin the discussion. You'll say, Kurt, you know, you had 1,000 operations, years and years of your life, setback after setback. Don't you wish you had just had the amputation right from the start? For me personally, the answer is no. And my two reasons why not are, first, I could never do my job with this leg. Not in a million years, okay? What's the worst thing that happens? I break my prosthesis. I get some new parts. I'm out of commission for a day. It's not a big deal. I could never have done, 7, 10, 12-hour operations on this. The other reason is not so much physical as it is psychological. I personally had to know that I tried everything possible to save my leg. That's where I was at. Not everybody comes to that decision in the same amount of time, right? I am a stubborn ass. I had to deal with a badly infected leg and 25 operations over the span of 6.5 years before I said, okay, well, this isn't working out. Some people are smarter than me and come to that conclusion faster. But for me personally, I needed that. And I'm sure we'll talk a lot about that. So this is the way my residual limb looks now. They are not stumps. Stumps are on trees. It looks beautiful. My leg didn't look that good for about a number of years. And then I roll this sleeve onto my leg. You can tell me if this is similar or different than the apparatus you guys have got. And I put on some socks, and then I pull myself in with a screwdriver. I put the flat end of a flat end screwdriver right there, and I kind of ratchet myself into my leg, and off I go. So sockets are not perfect. They've got problems. They can end in missed work. I've missed, in 11 years, I've missed 2 weeks because of stump problems. So they're not perfect, but please tell me whose life is perfect. Osseointegration is not something I've done personally, but it's something I think about. It's basically a way to have a prosthesis without a socket. And this is something we're doing at Pitt. And broadly into the idea of survivorship. And we are all the panelists, and Anne and even Christina are in different phases of this journey. But I think we've all faced the question, how do you put a life back together when the shapes and sizes of these puzzle pieces are no longer the same shape and size, right? How do you do that? How do you find your new homeostasis or your new normal? Or is there even such a thing? So the idea of sarcoma, specifically osteosarcoma survivorship, is something that I think about now more than I ever have. And I certainly look forward to learning more from the panelists. And with that, let's have a really good talk. Thank you.
That's great. Thank you very much. I just have a quick question right off the top, and then we'll switch over. Can you go from the type of amputation you had to an osseointegration? And how much bone, if yes, how much bone do you need to have?
So that is a wonderful and very, 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 very smart question. And probably the reason why I haven't done yet, because you do have to give up some bone, okay? Depending on who the maker is, you do have to give up some bone. And there are lots of different flavors of osseointegration, different platforms that people use that have different amounts of bone that you would have to give up if it didn't work. And that's why I got cold feet, because I can't, it's not just as easy as saying, well, I'll just go back to the way I was. The way I was wasn't so bad. It might not be quite, it's not quite the same. You would have to give up some bone. You'd have to give up some soft tissue. So that's probably the main reason you're not even an amputee, and you asked a really smart question. That's probably why I'm dragging my feet a little bit about getting it done myself, because I know it's not a free pass, right? Oh, if this doesn't work out, I'll just go back to the way I was. Sadly, at least in 2022, doesn't work that way. Great question.
I'll take the next question if that's okay with you guys. A really great question that came in. Did you consider rotation plasty for yourself? And how do you talk about rotation plasty with your patients?
Another great question. I suppose rotation plasty would have been technically feasible for me. We typically like to reserve that for our younger patients. You can do it because at the age of 15, I was pretty much, the same height I am now. I was essentially fully grown then. We usually use rotation plasty for younger patients, although that's not a hard and fast. For me, I did not consider it. I think for the right patients, it is fantastic because you can beat the crap out of them, and it basically turns what would be a transfemoral or above the knee amputation into a transtibial or below the knee amputation. I just helped my partner, Dr. Stella Lee, do one a couple of weeks ago. Dr. Megan Anderson from Harvard came down to Pittsburgh. She Stella had done her fellowship with Megan, and Megan was kind enough to come down to Pittsburgh and do it with us. And it went beautifully. And I think that patient is going to be really terrific. So do I think it's a great option for the right patient? 1,000,000%. Do I think that I'm not awesome at it and I would phone a friend to come and give me a hand? Absolutely.
Hi, I also have a question as well. If there is reoccurrence in the same spot that the tumor was originally in, that was kind of like a situation that I went through, is that I ended up getting reoccurrence in the same spot. Is there an advantage of doing amputation the second time, or is it also possible to do limb salvage the second time as well? Because I had limb salvage the first time, and
Right.
then is there an advantage?
So great question. Another great question. And the answer is it's controversial, and that is the God's honest truth. So do you have to jump right to amputation in every local recurrence? Probably not. In all of my osteosarcoma local recurrences, I've had 2 in my career. One I amputated, one I didn't. So I don't think it's hard and fast. I think the best author about that was Val Lewis at MD Anderson. She wrote a paper on that exact topic, and I'll see if Anne remind me and Christina remind me if I can get the citation for that paper, and we can post it on the MIB website so people can do their own reading. I don't think you have to. Oftentimes, though, in the setting of a local recurrence, it's in the setting of someone who's had chemo and has had surgery, and the damn thing came back anyway. So at that point, the chemo has declared itself as not being super duper effective, right? So what are you left with? Well, you're left with, you should probably do the most aggressive surgery that you can. If you think you can get away with it by doing a limb salvage, then absolutely have at it. That is not always the case. But I think what you're trying to get at, Kerrigan, is it a hard and fast 100%, this is what we do? Not always, not always.
Okay, so I'll get started on the patient perspective, not knowing much about the medical and surgeon aspect of it. But yeah, next slide. I wanted to preface this by saying that I only share this information to give insight on my unique experience and in no way attempt to persuade anyone to make any certain decision. I thought I would start off by talking about the old me. I tend to think of myself as different people because of how different I am now, not just physically, but mentally as well. The old me was defined by ballet. I had done pre-professional ballet since the age of 3 and majored in dance my freshman year of college. Ballet was entirely who I was. It is what I prided myself most on, spent hours, blood, sweat, and tears just to keep moving and keep active. I never wanted to be a professional ballerina, but I always knew that I never wanted to stop dancing. Next slide. Come January 2020, my first semester of college, everything changed. Dancing every day, I started to experience extreme knee pain. Dancers always have pains and aches, but this was far worse than I could ever imagine. After 3 months of misdiagnosis, they told me I had osteosarcoma in my left tibia. My days went from pushing myself to my maximum physical exertion to spending 23 hours of my day looking just like this, sick, asleep, and in pain. Next slide. I started standard MAP protocol, and as we all know, it was really hard. From my diagnosis, I knew I had to start thinking about making a decision about what surgery to opt for. When the time came to make the decision, I had a lot of different factors to weigh in. I was non-weight bearing because of the weakness of my bone, the pain was still terrible, and I developed 3 DVTs or blood clots below my tumor. The placement of my tumor as well as my blood clots caused me to lose sensation in my foot and instead feel constant pins and needles. I was on painful blood thinners, and my surgeon discussed how I might not be able to regain sensation in my foot if I choose rotation plasty or limb salvage. By that point, I had already had a good feel for what my decision would be. I knew a lot of people through social media and MIB who eventually got amputation after a limb salvage, and I saw and heard their struggles of relapse. I thought to myself that if it is potential in my future, I would want the surgery now to save myself from the future hurt. Another factor I was lucky enough to have was knowing an amputee prior to cancer. When I was younger, my dad had a friend who was a bilateral below the knee amputee. I remembered him as the man who had awesome bionic legs, and it always surprised me what amazing things technology could do. But the turning point, when my mom asked my surgeon what she would do if I was her daughter. After she validated our feelings about amputation, my decision was final. Next slide. Once the decision was made, I prepared for my amputation without even knowing I prepared for it. Emotionally, it was uncomfortable for me to think about for too long, so I took it slow. If I didn't want to talk about it, we didn't talk about it. The days that I did feel okay discussing it, my mom was there to listen and support me. We set aside a special shirt for me to wear on surgery day, which helped me admit that it was actually happening. Something that helped me both emotionally and socially was texting my friends and family and telling them in advance that I was going to get my leg amputated. Watching them handle and process it took some of the weight off of me and also made me feel more comfortable with others getting comfortable with it at the same time. I took it to social media as well. Before I went out in public with one leg, I wanted people to start to understand that it wasn't scary, it's different, and different is beautiful. All of this preparation took some load off of what I thought people would think of me and my choice. We threw a leg party with a leg cake. I took one last footprint, and my mom had people from all over the world send me nice notes, cards, and drawings, and I got excited for the idea of no longer having a tumor attached to my body. There were days when it hit me and it hurt, but I tried my very best to think of it in positive ways. Physically, I started physical therapy from the start of treatment to work the muscles I would need to keep strong. I beefed up on protein and made sure I stayed in as okay of shape as I could before surgery. This kept my stamina up and made me feel like I could take on surgery. Next slide. Before I knew it, surgery day had arrived. I went through the motions, as does anyone. The night before, you can see in the picture of me crying, I was sad. I was scared and worried and anxious and had all of the feelings. My main worry was of how much of a shock it would be when I woke up. Spoiler alert, it was not a shock. Coming out of anesthesia, I was very calm and at peace. The next picture was the next morning. My spirits were good and I was ready to get going and be done with surgery. Surgery itself went great. I got anxiety meds while waiting to head back to take the edge off, was feeling perfectly fine getting in my epidural, and went to sleep happy. It took 6 hours, no blood transfusions, and no oxygen needed. Even though my tumor was in my tibia, they amputated above the knee to ensure clear margins. The picture on the right is me fresh out of surgery, smiling and content. Next slide. Something I also prepared for was that things move fast post-surgery. They had me transferring from bed to chair the day after surgery and then on my foot by the third. They wanted to get my epidural out, get off of narcotics, and start dressing changes right away. It was overwhelming at some points, but it was also very good for the mind and body to keep going. My pain was okay. It is inevitable to have pain, but was well planned around with meds and what time I would be moving, doing PT, etc. Phantom pain and sensations was a lot different than I expected and very, very real. That also took navigation, the right meds and techniques to work past it. Next slide. I quickly dove into my new normal as an amputee, PT all the time. PT was crucial to be able to keep the muscle, lose some of the swelling, and keep my hip flexors stretched so that I could use a prosthetic. I maintained physical therapy for the next 6 months of chemotherapy and actually got fitted for my first prosthetic in September of 2020. I did this so that I could fully focus on one thing at a time: surgery, chemo, then walking again. Some people choose to get a prosthetic right away. Doctors and physical therapists typically guide the patient through their own process. For me, I got comfortable with a commode, rolling walker, and wheelchair. Crutches were not my personal favorite. I was also enlightened to learn my new normal with prosthetics, fitting for new sockets all the time. Next slide. And that brings me to life after amputation. I've done things I didn't think I could achieve being an amputee. It took me longer to learn how to walk than I expected, and I still struggle with many physical setbacks to this day. I have emotionally accepted my new body more, but still have days where I'm frustrated and sad. Sometimes this is at how inaccessible the world is and how ableist some people can be. Slowly but surely, I have been able to dance again, ride horses, anything that I want to try. Something amputees or soon to be amputees should know is that there's no limit. Where there is a will, there is a way, and anything and everything can be adapted with a little time and effort. I am proud of my decision I made and continue to get confident day to day. And that's all I have.
I have chills. That was so good. That was so good.
You are a very brave woman.
Thank you.
Really, like, and how much would you have loved to have watched what you just presented before you had an amputation, or like when you were, this is really valuable. And thank you so much for sharing that. Really huge. Kerrigan, how you doing over there?
Kara inspires me every single day. Since I'm on my third relapse with osteosarcoma, I've had a little bit of a different journey with my prosthesis, and I'm finally, since I am taking a break from chemotherapy right now, I'm finally able to get up on my leg, and she just encourages me every single day, and that was really encouraging to watch. And you're incredibly brave, and I'm really glad that you put that together.
Thank you.
There is a question for Dr. Weiss. Very good question. How successful in terms of functional mobility over time do you feel limb salvage surgery offers your patients?
They move pretty good. Again, the distal femur, the bottom end of the femur is a little bit easier, straightforward than the top end of the tibia. And the reason for that is that your tendon at the bottom of your kneecap that plugs into your tibia and lets you straighten your leg out. Well, when you do a proximal tibia megaprosthesis, you have to take all that off and tie it back down to a piece of metal and hope that it kind of scars in around it. Now, how well do you think that works? Most of the time it works okay. But in terms of mobility, distal femurs do pretty great right out of the box. But you don't get something for nothing, do you? You for sure will have more surgery in the future. You're not at your last operation. Things wear out. Things need to be replaced. So I think if it were the one answer were always the right answer, well, then we would always do that, and it would be fine, and there would be no reason for having talks like this. But nothing is perfect. It's all about what Kara just taught us, which is figuring out a way to make it work for your life.
I had a similar question come in when a patient is first diagnosed in your first meeting with them and their families. How do you engage with patients and parents about the surgical options? Do you use photos like you did in the presentation that you just showed us, and personal stories? How do you first engage them?
Okay, so another great question. That is not typically something that gets done in my hands at the first visit. It's too much, right? It's like, okay, this is what we're dealing with. You're going to meet the medical oncologist. You're going to start doing this. Just remember 3 words today: treatable and curable. That's all you got to remember for today. We'll talk about the other stuff later. Okay. And maybe a month later, certainly a few weeks later, I'll see them back. Okay, how's chemo going? And then, okay, well, we got surgery coming up in the future. Based on where your tumor is, these are your options, and this is what it looks like. I always include amputation in that discussion. Always. It is not a defeat. it is a viable reconstructive surgical option, and people do great. So, and I've had to do a lot of teaching, not necessarily to my patients and their families, but to my colleagues, right? That's, geez, I had to, okay, it's maybe not, maybe it's not what you wanted. It's not what I wanted personally, but I do okay. And I think that God Almighty, if we ever had a good ambassador for that, there's Kara, there's the two of you, and maybe on a good day, there's me. So I think that we've got to do a lot of teaching, the four of us, that, this isn't perfect, but who the hell's life is perfect? And like Kara said, with some adaptation and some creativity, you really can do whatever you want.
So related to that decision-making process and having that conversation, a couple of questions for you, Kara. Were you engaged in making the first surgical decision? And then did you consider rotationplasty? Was it an option for you?
Yeah, so I was 18, still in pediatrics, but 18 years old. So I was able to consent to my surgical option. And my mom really did try to listen and be educated with me, but left it up to me as my decision. And I think that's part of how I feel empowered, is knowing that that was my decision ultimately. I think for younger kids who are not at the age of consent, having open conversations with them and making sure they are still engaged is really important. As transitioning into rotationplasty, it was in question, but because of the loss of sensation in my foot, we were unsure if that was able to come back if we chose rotationplasty. I know if I had chosen limb salvage that I would likely be in a boot for the rest of my life. So I started changing the gears in my head more towards, okay, what can technology help me with now? What cool prosthetics can I look into, and start getting excited about that.
Can I make an observation? And Kerrigan and Mia, please offer your thoughts on this. I hope the viewers see that there's lots of different ways to come to this decision. Kara was much more mature than I was, and knew right away that this was going to be the right decision for her, and she was going to figure it out and make it work, right? For me, I had to go through some bumps in the road before I came to that determination. But for both of us, the way we did it was the right answer, right? So this is not a one size fits. This is a one size fits one when you're having these discussions with your family and with your surgeon and with God. And it's my job to make sure that I work with what your vision of this is.
When I was faced the question of the amputation, I immediately wanted to do amputation, and that was because I had drop foot from my previous surgery. The nerve grafts ended up failing, and I ended up fighting sepsis. So it was kind of, for me, it was a no-brainer, because I think at the end of the day, I do think it improves my quality of life. There was a lot of things that I struggled with, especially with walking, and the AFO wasn't the best for me. And at the end of the day, my prosthetic leg, I have a better gait, and I'm better at walking than I was before. So that was like a no-brainer for me. And it was kind of always going back and forth, like, will this improve the quality of my life? And it will. And of course, I'm also getting a clean margin. Yeah. So one question I did have is, I know there's different types of prosthetics, and I couldn't tell in your photo if you had like an implant type of prosthetic where it kind of hooks on, because I've seen it before where it's like you kind of like screw your leg into it, like you place a screw at the end of the residual limb.
Yeah.
Is there is that something that you offer?
I haven't done, so what you're describing is osseointegration. I haven't done one myself. If my patient, my partner, Rich McGow, my senior partner, has done a bunch of those, I would refer them to him. It's not ideal for osteosarcoma right off the bat, in my opinion, and this is why I think that. Because you still got to go and do your chemo, don't you? And you're going to have a healing wound with a big chunk of metal hanging out of your leg while you're neutropenic on chemo. To me, I'm a cautious dude. That I can't get over that in my brain. Now, if somebody were to be, whatever, 2, 3, 4 years out and everything's looking great and they wanted to be converted, okay, now let's talk about it, because now your immune system's okay and I don't have to worry about you being poisoned every couple of weeks. But for somebody who's in the thick of it, I struggle with that.
Yeah, and I'm definitely I'm not a doctor, but I do agree with you, especially being neutropenic and having basically a foreign object in your body. I know that can get tricky, just because you're not even supposed to get your ears pierced when you're neutropenic. So having an implant wouldn't be the best option.
Kara, this question is for you. As your friend, I know how fabulously funny you are. I follow you on all of your social media and it always cracks me up, and you are always an inspiration, even though I know that word is incredibly cliche. But how would you advise future amputees or people who have been recently diagnosed with osteo in general to lean into that positivity and not kind of get bogged down? Because I know it's healthy to have your down days, but how would you advise them to really lean into the humor like you have done so beautifully?
That's a good question. I think if some people know me, they know that I choose to tend towards the humor side. But I think it's also a point to make that is like a coping mechanism for me. And that can be a coping mechanism for people, is to kind of make jokes where it seems like jokes aren't allowed. But it's just the way that people cope. I think that sometimes I don't have the days where I want to make jokes about it, and I have the days where I just want to sit in my bed and cry and think this sucks and I wish I had my leg, and that's totally okay. I think at the end of the day, I am grateful for what I have, and I think therapy is great, and I think that I love therapy. But yeah, I mean, there were different ways that I have coped with it. For me, it was, having a leg cake and saying goodbye and trying to not feel terrible about it and thinking of it in a positive way of, I'm getting a tumor out of my body and I'm no longer going to have a tumor with me. Thinking of my leg as a burden instead of something I'm losing. It's something that I'm gaining, which is my life.
Hey, Kara, you spoke briefly about therapy. You guys are so far ahead of where I was when I was an osteosarcoma patient, and I probably should have started doing some therapy when I was 15. Instead, I started closer to 35 than 15, but eventually I got there, and I think it's terrific. Good for you guys. Good for you guys.
I definitely think that therapy is great. I think that sometimes you have to be open to it. I don't think it's necessarily super helpful if you don't want to do it, and that's totally okay. But there is that emotional side to amputation too, of seeing yourself as different, can be tough. Yeah.
Wow. So I'm going to change. Amazing. Like, first thing I'm going to do is follow Kara on social media after we get off the Zoom. And you all, I mean, just the way that like all of you have kind of spoke about your experiences is just really pretty amazing. And just your ability to kind of frame things in kind of a different way. Dr. Weiss, I'm just going to kind of ask more, go back to some of the stuff that you were talking about in the beginning, where infection was, always a big issue with limb salvage. And I feel like I've kind of seen bits and pieces about ways to try to address that, whether it's like a coating some type of antibiotic coating on the prosthesis or stuff like that. So are there any new developments that are starting to address those issues?
So yeah, silver is making a resurgence, coating things with silver. We've known since antiquity that silver has antimicrobial properties. So there's that. There's very exciting things. My buddy Nick Bernthal at UCLA does a lot of research in antimicrobial peptides, in coating big mega prostheses with that, because it is a big problem, right? You're putting a big piece of metal or dead bone in the case of allograft, and there's no antibiotic that's as good as a white blood cell, right? These things don't have a blood supply. And so you get an infection, it can be a real problem like it was for me. So I do think in the very near future, we're going to see coatings that help. Michelle Gert at Hamilton at McMaster University in Hamilton, Ontario, just published the results of her parity study. And this was the first ever randomized trial in orthopedic oncology. And she found that the rate of infection for megaprosthetics for all comers was like 17%. It is really high. And clearly, Christina, this is a nut we haven't cracked. And it's a good thing that people like Nick and Brock Lindsay at West Virginia and Ken Urish here at Pitt are doing research on that, because it is sorely needed.
I'll just put a plug that we're actually going to have Dr. Gert on an Osteobites on March 17th, and she's going to be talking about that study.
You will love her.
Yeah.
I didn't mean to steal any of her thunder.
It's a great preview. Thank you.
So we talked about this on the last Osteobites we had you on, Dr. Weiss, which was a day in the life of a musculoskeletal oncologist. And I think we all know from dealing with our musculoskeletal oncologists that they never sit down. Like for my limb salvage surgery, it was over 16 hours. So I can't stand for an hour without getting really uncomfortable and like starting to really seek a chair or a couch somewhere. So that's an extraordinary thing that you're able to stand and do surgeries for the, I mean, that's incredible. Like a limb salvage surgery, I don't know a lot of people with limb salvage surgery who could stand for that period of time and in one place and undertake that. And then you're probably up at the hospital at 6 a.m. and then you're there late. And I mean, that it's incredible to me that you're able to do that. As a limb salvage surgery person, I'm like, it's just not something I can do. It's just something I can do. So it's pretty amazing.
Thank you.
Can I follow up with a question to that? This is just like a random question, but do you listen to music when you're performing surgery? Like, do you get to
Constantly?
Okay. What's your like go-to surgery music?
So I tell the OR staff that they can play whatever they want as long as what they want is not country. I like classic rock. I'm old. So that's usually what's going in my room, but they can play whatever they want as long as it's not twangy.
Yeah. Heavy metal, like,
Oh yeah.
no big deal. We'll just bang heavy metal with heavy metal. No problem.
It works. It works.
Okay, guys, we are out of time and we have to give Dr. Kurt back to his patients who universally adore him from by all accounts that I know of. So thank you so much, Dr. Weiss, for spending this time with us. Again, it always means a lot to us. And holy cow, Kara, just amazing. And in perpetuity, this will be meaningful and helpful to so many families, having a real true account of what it's like. And then hearing from Dr. Weiss, it's just amazing. Thank you both very much. And then Mia and Kerrigan, awesome, as always, to have you and have your perspective on this. And thank you, of course, Christina. More information on this OsteoBites and all OsteoBites can be found on our YouTube channel, on mibagents.org, or wherever you get your podcast. If you registered for this session, you'll be emailed this final version of this OsteoBites, as well as any links that we've discussed. Those will also be in that email. Next week, if you would like to join us, we would love that. We'll be talking about truths and myths in nutrition in cancer. This is going to be with Natalie Ledesma of Integrative and Functional Nutrition Consulting. So come ready with your questions next week. I think that's going to be a good one. Until then, thank you again, Dr. Weiss and Kara Scrubis, and panelists Kerrigan Nelson and Mia Sandino, and of course our sponsor, BTG Specialty Pharmaceutical. Thanks everybody for joining today. Good health to you, and hope you have a nice weekend.